Christine, although the federal ministers denied it, it looks as if there's a facilitated environment for private health insurers to go into primary health care. And so the question is, where does the private sector, private health insurance play out? What do you think is the play there?
Well, I think it was interesting that there was very little about private sector in that budget. Maybe that's in times to come. There was, of course, the pausing of and the changes to the Medicare levy surcharge. In terms of facilitating entry, I'm not really quite sure that it facilitates entry for the private health insurers, but I think private health insurers are very interested in the primary care space. I think the primary care networks that are being developed, and as you know, we don't have the formal response from the government yet and from the Department of Health as to what will happen, but in Dr. Horvath's paper, it was envisaged that primary care networks, which are the facilitative entities, would be open to other players, including the private sector and not-for-profit sector, so that may be an opportunity. But I don't know that it's facilitating private health insurers moving into primary care, to be honest.
No, I'm just suggesting that might be in the minds of the government to allow them in.
Well,
and reputedly, Medibank and Bupa are both preparing and nicking Medicare local staff to prepare propositions to run primary care networks.
Yeah, so the primary care networks, health insurers have been long interested in primary care because, as we know, it is the foundation of healthcare, and if you're wanting to help someone manage their health risk and get the right care at the right place at the right time, you need to be working with primary care providers. So that's not new news, but I expect that, well, they already are, and they will continue to increase their presence in that space. But I would throw out the question, state governments, could they become more involved in primary care as well?
Yes.
To integrate.
Brian Pizzuti from Northern New South Wales. Christine, I wonder whether the new primary care arrangements may attack the really big difficulties of the socio-economic differences, particularly between country and city, and the access that people have to the services in a more equitable fashion.
You know, I think I don't know what's going to happen. We obviously don't have a crystal ball. But the important thing is if you bring in co-payments, and let's face it, our system already has co-payments, and in fact, as a nation, we pay probably more co-payments than most OECD countries. We're just above average in our out-of-pockets. So it's not a new phenomenon. The big question when you introduce a co-payment is, what are you trying to achieve? Are you trying to get people to think twice? Are you just bringing in revenue source at point of use because you think that's actually a good thing to do? Whatever your reason, then what do you do to protect those who are most vulnerable and to reduce inequity? And to me, there's two elements. One is what you exempt from the co-payment. So, as I was saying, immunisation, chronic disease plans, cancer. There's a number of things we really want people to do, and we don't want any financial obstacle in their way. But there's also safety net provisions. And so, again, the safety net provisions would need a particular focus. In terms of rural and city, I mean, we've already got a challenge. I suppose it also depends on whether practitioners and practices choose to go with the bulk billing with $7 copay, or whether they have a larger copay, as many do already.
Thanks very much indeed. Barry?
Thank you, Christine, particularly wearing your Medical Research Australia hat. Two questions about the Medical Research Fund. Why do you think they use the word medical and not health? And secondly, how can we be assured that there won't be clawback in other sources of revenue for medical research?
Well, at the lockup, budget lockup, the Secretary was very clear that medical research the Medical Research Future Fund was the name, and that there is a focus on medical research. But the government's been consulting, and there's been a number of consultations held around Australia, and I think they're hearing from people the importance of health policy, health systems, clinical applied, population and public health research. And I think it's a journey yet to determine what this fund will look like and how it'll be invested. In terms of clawback, the NHMRC funding projections are maintained as well, as far as I could see in the forecasts, and state research funding is still in the state's purview.
So I want to ask you about workforce, and this goes into sort of an area of conflict of interest for you, but we'll see how you deal with it. The mid-level prediction of HWA, at least a year or two ago, has about 1,200 unemployed doctors by about 2019. There's a potential for unemployed nurses. To what extent and that will create a political issue in the country, to what extent will that pervert what's going on at the moment now, which is role expansion, nurse practitioners being developed, to get integration where you're getting the most effective care by the most, people working to the maximum of their capacity of training. How do you see that playing out? I mean, that's your bread and butter now these days.
Yeah, well, the first statement, my understanding of the projections was that there was still a shortfall in medical workforce by about 1,000. So I'm not sure about the projection of 2,000 unemployed. 1,200, okay. So I've got it the other way around, that there was still a gap. But the real issue with particularly the medical workforce is not just the numbers, it's where they work. And I guess supporting a rural and remote practice, which, as you know, there's many dimensions to doing that. The current rural clinical schools, recruiting from rural areas, training in not just as interns or as medical students, but also interns and in the vocational training, so that people can make their home in a rural area, having locum support, facilities, ongoing education training, and opportunities to be involved in teaching and research in the rural areas, I think are most important to the distribution of the medical workforce. So what was your other question in regard to
the question is whether,
if
you don't accept the original premise that there's going to be unemployment, then the question becomes null and void, because you create political pressures along those lines.
I think that the real challenge is the bottleneck. We talk about internships, but actually then there's the whole rest of the vocational training pathway. So the real bottleneck, and perhaps this is the unemployment bit, is people waiting to try and get onto training schemes. And I think that's where Health Workforce Australia, with state governments, private sector, not-for-profit universities and colleges, need to work together to ensure that we train the doctors, they get registered, but then there is the ongoing vocational training available for them, whether they choose primary care, specialist care, and in my view also stronger generalist care for generalist physicians and surgeons, so that we have those generalist skills in the health system, not just in rural areas, but I personally believe in metropolitan areas as well.
Just a final and quick, it's not a quick answer, but the final question anyway, is it comes back to my original one, was what innovation do you think needs to take place if you're going to work more in partnership with the private sector? The private sector is taking a lot of burden, a lot of clinical oncology happens now there, elective surgery, we know the story. And there's also an opportunity to work with the private sector, but it's an uncapped system, fee for service, and where it's hard to control costs in the private sector, as you know well from your Bupa days. What reform, if a state government was going to work more innovatively with the private sector, how might that play out?
Well, I think there are a couple of levels. One is the public-private partnerships, such as Northern Beaches, that is well underway. Another is having the purchasing and contracting of services from the private sector in a contestable way, which is part of the public systems service load being delivered through a private provider. But I think at a more sort of structural level, I would point to the Medicare Select suggestion, because frankly, if you want private health insurers, or any insurer, a social insurer, even Medicare or the states, to be involved in managing someone's health risk and their whole continuum of care, they need to play across that whole spectrum, and they need to see the benefits of savings from what their funding is actually going to. And one of the problems with the current siloing, and even for health insurers who only pay for sections of our care, they aren't going to make these savings by, on their own benefits line from some of the interventions that they would put in place. It'll be the public sector, or it'll be someone else making those savings. So when you have one health dollar and you have and responsibility for a person across their lifetime, across the spectrum of their care, I think you can do more innovative things and expect a return on that investment.
This gentleman, please thank Christine Bennett.